Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have here a case of a patient who has to attend every 6 months or so to have both ears cleaned. And on this occasion, it was their left ear that was the worst one out of the two. They suffer from chronic otitis externa. And otitis externa is an umbrella term given to an outer ear infection or inflammation. And the outer ear is made up of the ear canal itself, the outermost membrane of the eardrum. So the eardrum is in total consists of 3 membranes. The outermost membrane is made up of the same skin that lines the ear canal. You've got a middle membrane, which is made up of fibrous tissue, and then you've got the inner membrane, which is a mucosal membrane. So mucosal skin is similar to the skin that lines the inside of our nose, so it's secretory. And finally, the cartilage we have on the either side of our heads is called the pinna. So that's the outer ear. And when either of those elements that consist of the outer ear infected or inflamed, the label given to it is otitis externa. The term otitis is, I believe, Latin for ear infection, and of course externa is the location, so the outer ear. They have been prescribed some heavy dose corticosteroid cream for this, and they initially used to apply it using their little finger. And this has been prescribed by ENT, and on their last occasion, I recommended they just apply a thin veneer on the end of a cotton bud. Now, yes, we don't normally advise people to put cotton buds in the ears as it can push the wax further in, but it's going to be far more effective than using their finger, because with their finger they could quite easily graze and scratch the ear canal. It's still possible to do that with a cotton bud, of course, but if you've got a veneer around it, it's going to provide a safe buffer. And this patient was previously being assessed by an ENT colleague of mine, and they used to clean her ears out regularly, but because of the availability of my ENT colleague, they recommended the patient to come see myself instead. And fortunately and thankfully, the patient's been really happy every time they've come. Now, you may have noticed I'm using a Jobson horn, and the primary reason for that is this patient also suffers from unilateral left-sided tinnitus, so this is their left ear, and we're not sure of the underlying cause of it. They've had an MRI scan which came back clear. The reason why the patient underwent an MRI is if you suffer from unilateral tinnitus and it's like a daily occurrence that lasts more than 5 minutes at a time, or it's worse in one ear, or if you have asymmetrical hearing loss or unilateral hearing loss, so worse hearing in one ear than the other, or only a hearing loss in one ear, there's the potential that you may have a benign tumour called an acoustic neuroma, also known as a vestibular schwannoma. And that's essentially a non-cancerous soft tissue growth that originates on the balance nerve. Now, the 8th cranial nerve, also known as the audiovestibular nerve or the cochleovestibular nerve, consists of the auditory nerve, so the hearing nerve, and the balance nerve, so also known as the vestibular nerve, and they're intertwined. They're very close proximity to one another. And a vestibular schwannoma, or an acoustic neuroma, as is also known, it originates on the balance aspect of the 8th cranial nerve, and it can grow and expand and impinge on the auditory nerve, resulting in a typically, not always, but a high frequency hearing loss. And that's because the high frequency fibers that line the auditory nerve are more on the periphery, on the surface, so they're more exposed to the soft tissue growth, and that can also lead to tinnitus. Other symptoms associated with an acoustic neuroma is vertigo, veering off to one side when you're walking, so disequilibrium. You can also get facial numbness on that one side, possibly facial paralysis or Bell's palsy. And that's because it can also impinge against the 7th cranial nerve, the facial nerve. And in fact, I had a patient today who attended with Bell's palsy. They had a middle ear infection, and which caused inflammation of the 7th cranial nerve, and it has improved. Fortunately, they had droopiness on one side, watery, itchy eyes as well, an inflamed eye, and it has settled, but the hearing hasn't. So again, we've referred them on to ENT. They'll need further investigation, most likely a scan as well. Sounds as though they're suffered from an acute sensorineural hearing loss. So they've lost they did lose their hearing suddenly. So they had a viral infection which affected not only the 7th cranial nerve, but which is now resolving, but also the 8th cranial nerve, the cochleovestibular nerve, so the auditory nerve. But the auditory nerve hasn't recovered, and there's still a hearing loss. And there is a critical time window. If ever you lose your hearing suddenly, it's always best to go and see a doctor, audiologist, even A&E if you need to, as soon as you can. Because if it is caused by a viral infection or an autoimmune response by the body, there's a 48-hour time window if you're prescribed oral steroids. Sometimes they can also be injected via the eardrum, so it's called intratympanic cochlear perfusion. The hearing loss can be reversible, or at least in part reversible. So it's very important. Now, of course, you can get a sudden hearing loss just due to wax, and it's just created a complete seal. You could have had a middle ear infection, you blocked eustachian tubes. There's a number of factors, but it's not something I would recommend just to ignore. So definitely get that investigated. So the patient has tinnitus in this ear, and I wanted to avoid using suction as much as possible. So I removed the majority of the debris using a Jobson horn. At that stage, I showed the patient the inside of her ear, and I asked whether they were happy with this. Because we could, at that stage, the whole eardrum was visible, they could hear it a lot better again, but they have got this kind of coating of, and I would say this is a combination of dead macerated skin, so skin that's shedded from the ear canal but failed to migrate, and that skin kind of just decomposes, it wilts, it becomes damp and moist, it can absorb any moisture or water that may enter the ear and then overhydrate, swell and burst. It becomes very mushy and macerated. Also, as I mentioned, this patient uses this prescribed heavy-duty corticosteroid cream, and I'll discuss that a bit later, because we've given some advice to the patient surrounding that. In fact, I'll discuss that now. So this particular cream, it's really effective, they've got the ointment version, and there's also a cream version, and the ointment version is very greasy, just like this, and that's designed more if the skin is dry and itchy. The cream is, after doing some more research on what they've been prescribed, the cream is more effective for more moist and damp skin and weeping skin, and that's what this patient's got. And I suspect a lot of this debris, it's not just damp, dead skin that has died and failed to migrate, and any product discharge secreted by any bacteria or fungi. I also think a lot of this debris is a collection of the ointment they're using. So the patient's going to speak to their GP to see if they can have the cream prescribed instead. Now, they've tried in the past oral antibiotics. They've also tried topical antibiotic sprays, antifungal sprays as well, but they just don't work for the patient. In fact, they can exacerbate their symptoms. The patient doesn't enjoy using them. So the cream, is this particular ointment that they've got currently, is the only thing that really helps the patient. So if they're going to try the cream format, because the cream format may not lead to the ointment, as is the case here, also almost amalgamating with the dead skin and causing a blockage in itself. If you imagine if you have a bottle of Vaseline, it's a very similar consistency, this ointment that this patient's got, and you put that Vaseline in your ear, because of the consistency of it, the thick glutinous greasy substance, that can collect in the ear and itself block the ear, where the cream is more likely to permeate the skin and be absorbed. So it's worth a try. Now, this patient has got extremely tender ear canal. The skin's very sensitive, so it was so important that I avoid touching the canal wall. So it's quite challenging at times, because we're in very close proximity to the canal wall. In particular, when we're using the Jobson horn, we're having to just almost hover over the canal wall without making contact, or if we did make contact, very minimal, low pressure contact, because it was the skin was almost stinging for the patient. We're not sure of the cause of why this patient suddenly developed chronic otitis externa. They don't get water in the ear. They're not really in humid conditions. So I've recommended they try and see a dermatologist. It could be some sort of allergy. They don't suffer from eczema or psoriasis anywhere else. They did mention that their a family member suffers from eczema, so there might be some genetic link there, but this patient's skin everywhere else is fine. They are not going through menopause or perimenopause. They're a bit young for that at this age. So there is anecdotal evidence, at least that I've myself noted, that patients who suffer from menopause or perimenopausal have very similar condition to this. They suffer from excessive dead skin accumulation. It's not really documented about it being in the ear, but patients who suffer from menopause, perimenopause do get dry skin, itchy skin, should I say, irritable skin, other parts of the body. But I've definitely noticed a link, a correlation. So I said the term correlation because you may be aware that in the UK tomorrow, King Charles is going through his coronation, and I was just watching the news, and hence why that term was in my head. But I was meant to say correlation, not coronation. There is a correlation between, in anecdotally anyway, patients who are menopausal, perimenopausal, and have this dead skin accumulation in the ear. So how would I best describe this? I would describe it as macerated dead skin. So I was explaining to the patient where almost the physiology behind what's going on in their ear, and I explained that the ear canal has a layer of skin that lines it. The skin varies on the outer third. The outer third, the cartilaginous portion, the skin is made up of 3 layers, and it's a lot thicker. You've got the epidermis, which is the outer layer of skin. You've got the dermis, which is the middle layer of skin, and then you've got an inner insulating layer of fat and connective tissue. So it's 3 layers thick, 1 millimeter in thickness, thereabouts. And then the inner 2/3 of the ear canal, the bony portion of the ear, is made up of the epidermis. It's the outer layer, which is less than 0.1 millimeters in thickness. So it's 1/10 of the thickness compared to the skin that lines the cartilage. But this epidermis layer is so critical. It provides a physical protective barrier, so it protects the dermis and the layer of fat and connective tissue in the outer third of the ear canal, and the bone that the skin sits on in the inner 2/3. So the epidermis is your outer layer of defense. It protects the inner layers that it's coating and lining from harmful pathogens, so harmful bacteria, fungi. That epidermis also helps the inner skin to retain its natural moisture. So sitting on the surface of the skin is a thin veneer of fatty oils and sweats. They're hydrophobic, so they repel external water from being absorbed by the epidermis skin. So because the skin likes to absorb water, and it can unfortunately overhydrate, it can overabsorb and then swell and expand and burst the membranes. And it also then helps to retain internal moisture from the skin because of the hydrophobic layer, so it traps the moisture inside. Now without that oily, sweaty veneer, internal moisture can rise to the surface of the skin through the epidermis and evaporate, and any external moisture can get absorbed by the epidermis layer, overhydrate, swell and burst, and then that outer layer of skin is breached, that protective membrane is no longer there. So this skin, it's almost as though the skin is overhydrating, it's absorbing moisture, absorbing humidity, and it's just swelling and expanding and bursting at the membranes. It could also be the skin that the moisture within the skin cells is rising to the surface and being absorbed by the outer skin cells as well. And again, similarly, absorbing, overhydrating, and then bursting and swelling at the membranes. So you can macerate fruit, for example. You can put it in a sugar syrup. Strawberries are a very common fruit that a lot of restaurants macerate, and it softens the fruit and it gives a more intense flavour. So not that I'm suggesting you try and taste the macerated skin in the ear, but it's a similar concept. The skin has become softened and damp and wet, and the skin that has died fails to migrate, and it almost decomposes in the ear, and then bacteria and fungi can feed on it. It's a vicious cycle. the patient's going to try a dehumidifier in the house just in case there is humidity or excessive humidity that the patient themselves are not fully aware of. I had a case with a patient a few years ago where they had chronic otitis media with effusion. So essentially it had a build-up of catarrh, glue fluid behind the eardrum, and that's because their nasal passages kept getting blocked. The eustachian tube, which is the drainage tube in the ear, it's also the pressure equalizing tube in the ear. It allows any fluid that accumulates in the middle ear, because remember the middle ear is made up of a mucosal membrane, it's a secretory membrane, and fluid can drain out of the middle ear because we don't want fluid in the middle ear, out of the eustachian tube, through the back of the nose, and either down your throat or it comes out your mouth. And this particular patient, she wasn't really aware that the house that she was living in was very humid until it was highlighted to her by a family member. And for years, she kept suffering from chronic nasal congestion and inflammation, which then led to this glue ear. And she just so happened to move house with no humidity, excessive humidity anyway, and her symptoms resolved. And she had multiple grommets fitted as a result. It was just due to the humidity within the house. So this patient's going to just try a dehumidifier in the house just to see if that helps, because otherwise they're going to have to come every 6 months to have this ear clean, which is fine. I'm more than happy to do it. But for the patient themselves, it's for the rest of their lives having to have their ears cleaned every 6 months. It's kind of a big undertaking for them. So we're going to see if it works. They're going to speak to their doctor to see if they can get referred to a dermatologist. They may be able to offer better advice as well, because that's what they do. We'll take some swabs of the ear, some blood tests, check for any allergies. And the patient's doing everything else right. They are avoiding water in the ear when they're showering and bathing, and they're not poking and prodding in the ear. So similar to the patient's left ear, the epidermis layer of skin here, once we remove all this debris, it's quite inflamed, it's sensitive, so again, we want to avoid touching it. In both cases, it was like the game of operation. We're just trying to avoid touching the canal wall. No doubt on occasions we did make contact, but it was very minimal and noticeable to the patient. On this outer third of the ear canal, I am putting a bit of pressure on there because this is less sensitive for the patient. It's more the bony part that was sensitive. And I'm just scooping away and vacuuming at the same time all this debris that's collected in the ear. Just a bit of skin at the roof of the ear canal. So it's quite a tedious procedure. It's quite a time-consuming procedure. If I used suction initially, it would have been a lot quicker because I could clear larger volumes of debris, dead skin, the ointment that they're using in one go. But because we use a Jobson horn and using a fine end suction probe to minimize excessive noise in the ear, it's just taken us a lot longer. So we're on the bony part here, just trying to hover over. There's a piece of skin here. You'll see that it was toying with me. It started to peel, but it kept flapping back, and I had to come in and out of the ear several times just to reposition, get a better grip, get an angle with the sucker to finally remove this. Definitely, this patient should not have their ears irrigated or syringed, because the water will only exacerbate their symptoms and their condition. So we're going to keep it as dry as possible. That's the secret. So just going to go back in and try to lift this layer of skin. There's very little margin of error here. So this layer of skin's probably approximately 0.1 millimeters in thickness, so it just gives you some perspective. And just slowly going towards the eardrum and lifting the sucker up just to detach it. You can see it's just peeling away. Now, the patient wanted me to get as much skin out as possible. It was their choice because all that debris was exacerbating their itchiness and irritation. So the patient's aware of the risk. They knew that there's only so much I could do without using suction. This is, the patient doesn't suffer from tinnitus, so there's less of a risk using suction here, but definitely the left side I wanted to avoid as much as possible. Now, quite often we get inquiries from patients asking that we remove the wax without using suction because they suffer from tinnitus or hyperacusis. We have to explain that it's not always possible to remove wax without using suction purely using mechanical instrumentations like curettes and hooks and scoops. Of course, we'd always make attempt to if possible, but if the wax is right on the eardrum, for example, well, we can't really scrape stuff off the eardrum, so we're going to have to use a bit of suction, or depending upon the consistency, the ear anatomy, it's just not always possible. So we make the patients aware prior to booking that we'll obviously always make attempts, but it may not be possible, and at that stage I'll explain to the patient that there's not much more we can do with the mechanical removal. We have to resort to suction if they want us to. If we don't just do it, we have to obviously advise the patient and let them make an informed decision. So again, I'm just mopping up here, just around the edge. I think I'm going to use the Jobson horn in a moment just to mop up this bit. This is near the entrance. A fine end is really good though. A fine end significantly reduces the noise level. Some people actually find it therapeutic because it's just like a good noise level. It's not excessive. And when you do have patient suffering from tinnitus and you're having to use suction because you've got it's the best and safest option, or the only option, you can go in and out of the ear on a regular basis. Don't overexpose the noise for a prolonged period of time. So that's another way around it. But the fine end definitely is a good instrument. A fine end is an extension to the normal Zollner suction probe. So a normal Zollner suction probe, approximately the outer diameter is about 2 mil or 2.1, and the internal diameter is about 1.6 or 1.7 mil. With a fine end, the outer diameter is around 1.3 mil, and the internal diameter is about 1 mil. So it's almost half the internal diameter, which means half the suction noise. Is it less powerful? Now, yes and no. Because of the smaller surface area, it actually can create more suction grip but on a smaller localized area of wax or skin. So if you reduce the surface area, you're going to increase the pressure. But if you're removing a big piece of wax, for example, it's just not got enough surface contact to remove that. But at the point where it is suctioning on the wax, that particular localized point where there's contact, there is probably increased power. There we are. So that's the patient's eardrum. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.